Good afternoon, everybody, and welcome again to our next webinar for WSH Kidney Lifeline, funded by the National Lottery Community Fund and the government. I would like to introduce two people supporting me today. The first person is Yemi and Oscarine. I really appreciate the support today, ladies. So very quickly, Yemi, would you mind to say a few words today, very briefly, because we don't have a lot of time?
Okay, hi, my name is Yemi Aina. I work as an IST consultant. I'm part of the trio of WSH, and that stands for Warrior Survivors and Heroes. The other two being Hilaria and Faith. Hilaria is an NHS organ donation ambassador, and Faith is a renal nurse. So we're going to be introducing Dr. Campbell shortly, but before then, I'll pass it back to Hilaria so she can talk through what will be happening today, and also introduce Oscarine.
Thank you very much. So, Oscarine, you have anything to say today to people who are watching?
Hi, my name is Oscarine. I've been a renal patient for the last 27 years. And during that time, I've had 2 transplants, and I'm currently on hemodialysis. Apart from that, I'm a teacher, language teacher, and I'm also an author. And I'm here today just to help Hilaria. Thank you.
Thank you very much. So they will both be behind the scenes, manning the questions as well as I'm going to be doing, and we'll put them up as they come. So please keep the questions coming. We're going to have a break after the first talk, which is Transplant First, and Yemi will tell you what to do, at that point. Today we have Dr. Tunde Campbell with us. I'll just put him in on now. We have Dr. Tunde Campbell, a consultant transplant surgeon in Manchester. If you are a kidney disease patient or transplant patient at MRI or Salford Royal, you would have met him at one time or the other, or you are his patient. I'm so proud to say I'm one of his former patients, and he did my fistula, which is still buzzing away. I'm not advertising at all. I'm sure a lot of people have been waiting for this. So without too much delay, I'm pleased to introduce Dr. Tunde Campbell. Welcome, Dr. Tunde Campbell.
Thank you very much. Thank you for all those people who have tuned in to listen to this presentation, and also to ask some questions afterwards. So I'm going to start my presentation by telling you what I do. I do kidney and pancreas transplant, and I also do vascular access surgery. So I'm going to be talking first about Transplant First. What is Transplant First? Why are we talking about Transplant First? Now, by way of introduction, as we all know, kidney transplant is the best treatment for patients with end-stage kidney failure. Why is this? Because it offers the best quality of life and also longevity compared to dialysis. Also, because preemptive transplant significantly improves long-term survival for recipient and also for the allograft. What do we mean by preemptive transplant? That is transplant without dialysis. Now, if we go to the figures in the UK, we find that only about 9 to 28% of patients diagnosed with end-stage renal failure have a transplant first without dialysis. Therefore, we have about 70 to 90% of patients diagnosed with end-stage renal failure will have dialysis first. And if you look generally at the renal replacement therapy population, 55 to 55.7% of patients in this group have received a transplant. This is by Renal Association report of 2018. There's a gentleman called Davis who did a study that suggests that if patients are evaluated before starting dialysis and listed on the waiting list, it may be possible to transplant 40% of patients preemptively. So that means there are some opportunities that we are missing at the moment. However, kidney transplant is cheaper than dialysis in the long term for the NHS. Therefore, I'm sure many of you listening are thinking, how do I improve my chance of receiving a kidney transplant? We're going to be going into that. And before that, I'm going to tell you a few things about dialysis and transplant, which many of us already know. Just to highlight the point about Transplant First. As we all know, most patients on dialysis will receive dialysis 3 times a week. That's 4 hours each time. That's a lot of time in hospital for those who have in-center dialysis. The removal of waste, by dialysis is incomplete. Some have even calculated to be at about 12% of what a normal kidney function actually does. Now, even the effectiveness of the replacement of other functions of the kidney by dialysis, such as acid-base balance, is EPO secretion, vitamin D, renin, and all those things, dialysis cannot offer any of those. So you have to resort to using other methods to replace kidney function. Now, when patients are on dialysis, the damage caused by end-stage renal failure is not, it does not recover. In fact, cardiovascular disease actually accelerates. And also complications of dialysis, looking at complications such as dialysis dementia, disequilibrium syndrome, and so forth. These are problems that patients on dialysis are still exposed to, though they are on dialysis. Dialysis does make people to survive and keep living, which is very good. But in terms of the quality of life and longevity, when compared to transplant, dialysis actually is not as good as transplant. What has transplant got to offer? The kidney works 24/7. Compared to dialysis, you only get 4 hours 3 times a week. You get 24 hours of work from a good working transplant kidney, with the potential for normal function of the kidney, that is producing EPO and all the other hormones that kidneys produce generally. Most people want to spend time away from hospital, not in hospital, because that's where you live. And then you have an opportunity for employment and better family life when you have a kidney transplant. And although the downside of kidney transplant is you need a lot of time to prepare patients for transplantation. There's a lot of workups, a lot of tests that needed to be done, a lot of education that needed to be given. And recently, the COVID-19 pandemic is actually also creating problems with access to theater to perform the operation. Now, we also have complications of immunosuppression to contend with, including infection and cancer. When you hear a diagnosis of kidney failure, most people feel shocked. Some people feel really devastated. Some people feel upset. Some people say, oh, my future plans, what's going to happen to all the plans I've had that I really want to do? Some people feel like, oh, I'm not sure what's going to happen to me. What about my friends? I'm going to lose them. How about my relationships? And some people feel, no, it's not happening to me. No, it's not me. It can't be me. And some people feel, oh, actually, this kidney is probably going to start working again one day. I'm going to wake up one day and it will just start working again. There are a lot of different ways that people feel. And this can be so overwhelming that some patients feel numb and they are unable to share their feelings or with their family, or share the diagnosis of kidney failure with their close friends. What I like to say is that it's okay to not to be okay or not to feel okay, but because there is light at the end of the tunnel, the timing of the next steps that you take actually matter. And it's now about education, 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 because it's like going back to school. There's a lot of information that needs to be passed on to you, and for you to imbibe, to be able to take advantage of the opportunity of a kidney transplant. Now, what has the healthcare professionals done about this problem? Like we said earlier, only 9 to 28% of patients get a kidney transplant without dialysis. And we say kidney transplant is the best treatment for kidney failure. And we say kidney transplant is cheaper than dialysis in the long term. Why is it that many people are getting kidney transplant? Why are they not getting the best treatment? So these are the efforts that have been put forward to try to mitigate against this issue. And one of which is to increase the number of transplants from living donors, because it's predictable. It's got better quality organs that you can get from living donors, and it's a planned procedure with a better outcome for patients. The second is to increase the number of preemptive transplants, which is because this is the best treatment for end-stage kidney renal failure. And also to increase the number of patients entering the transplant waiting list before they start dialysis, which is key, because this increases the chance of kidney transplantation. Although staying on the waiting list is unpredictable, because the waiting time could be up to 3 to 4 years for some people. Now, the workup for transplantation can be very, very complex for some people, because it involves multidisciplinary teams working very closely together, and there's a lot of resources that is needed to make it work. And all steps should work for each patient to achieve set objectives. Everybody is different. They have different problems, different issues, but those clinical pathway has to work for everybody. It is not easy. Now, the objective of working patient up for transplant is to make sure they are fit, so we don't harm them, because doctors are the main objective of treating patients is first, do no harm. And also we have to be sure that the complications of transplant surgery is not going to be overtly increased for patients, for some patients, and also to make sure that the difference between benefit and harm is well balanced out. We also want to determine the HLA or tissue type and also antibody profile of the patient to make sure we can match them when a kidney becomes available. We also have to determine the benefit from a transplant for every patient that is worked up for kidney transplantation. So the key is education of the staff and patient, education of healthcare providers, education of the entire community, education about living donation, about disease donation. There is a lot of effort that has been, and a lot of resources has been put in to try to achieve this goal, Transplant First. I can tell you there's still a lot of work going on now to try to bridge this gap, to increase the number of patients who get a kidney first before they need to start dialysis. So what can we do? Early diagnosis of kidney failure is very, very important. The patient has to make a decision about what type of treatment they're going to get. And they have to make a decision about what type of dialysis they're going to get, type of access they're going to get very early. And some patients actually benefit from speaking to other patients who are already on dialysis or who have already had kidney transplant to give them a little bit of support to be able to start their journey in receiving a kidney transplant. Also, it's very important that family members are brought in, because when you hear about the diagnosis of kidney failure, most people feel really numb. They can't really make any plans, but the families can do that for you. They can start making the plans for you. Now, in summary, kidney transplant is the best treatment for patients for end-stage renal failure. Unfortunately, we need a lot of time to prepare patients for kidney transplant. And I think it's very important that we'll encourage early placement on the transplant waiting list before the need for dialysis. It is also important that patients, their families, and healthcare providers work towards removing bottlenecks in the clinical pathway. Thank you. I'm ready for your questions.
So thank you, Dr. Campbell. Thanks so much for taking it, going through all of that really, really valuable and useful information. I'm quite confident patients will now have the information they need that would equip them in helping them to make a decision in terms of the options they would need to go to start their treatment. So at this point, we'll take a short break, 2 minutes break. And then please send in your questions and we'll start addressing them when we come back home. So we've just got comments at the moment. Both comments are saying thank you to you for the gift of your time and giving this informative talk. And Adeolaito is saying thank you, Dr. Campbell. Please feed through your questions.
Some questions have just come through, Dr. Campbell.
Yeah.
One of them is, must a living donor be related to me?
Okay, we can answer that. Yeah, when we come back from the break.
Okay. So Yemi, what do you think? so far,
it's quite eye-opening, because these are things that you don't really think about if you're not exposed to somebody going through it. And it's from being from getting to know you that I'm now getting to find out about the challenges and everything that has to do with kidney failure and also the treatment relating to them. So the talk by Dr. Campbell today is really quite helpful. And I think what he said in terms of helping the friends and family in particular to understand what it's about, so they know and they can help the patient to make really useful decisions in terms of what needs to how the patient, what they need to do, what their options are to move things forward for them in terms of getting them better, getting them ready for transplant.
Yeah.
So it has been very, very useful. It's short but sweet, very full of really, really valuable information. I'm sure a lot of people will be more enriched having listened to it. I think, yeah, I could see, sorry, I can't remember your name.
Oh, Oscarine.
I can see Oscarine was quite moved by that as well, by the update.
Oscarine, were you?
It is quite interesting, everything that he was talking about, especially the education part, because when you really don't know what's happening to you, it's very easy to give up. So And he talked about the involvement of everybody, including the family, because if you don't have that family support, you're gonna feel overwhelmed. In my case, I am telling you, when I started dialysis, I was a minor. My family was shocked. They were numb. I wasn't, because I didn't even know what it was. They're the one that were taking all the blows and making all the decisions. So if they were not there, had they not been there, I wouldn't be here today, because they did everything that they could. So that I could be here today. So family involvement. Oh, it's very, it's very important. It's crucial. You know that, Hilly. It's crucial.
Yes,
it's crucial. So yeah.
Because my family did the same thing. I have 7 brothers and sisters, and my parents as well, and everybody came forward. Unfortunately, none of them was a match. Can you imagine that? A family of 10, 9 people came forward. Not one single one was a match. And thank God, I got on the list, and I was transplanted after waiting for 6 years technically, but 10 years altogether. So that is just amazing. So thank you everybody for holding on. I hope you've got your water, you've got your tea, coffee. I'm going to put Dr. Campbell's going to come back now, and we're going to go on to the next topic. So so keep the questions coming. We can see your questions coming in. So just keep the questions coming. Oscarine, you want to take it away to introduce Dr. Campbell?
Okay, thank you everybody for coming back. Thank you for tuning back again. And we're gonna have Dr. Campbell coming back to continue his talk, but this time it's going to be about that your dialysis access option that you have. Okay, let's welcome Dr. Campbell now.
Hello, everybody. You all welcome back. So this time I'm going to be talking about dialysis access. What is dialysis access? Access is a conduit that we usually create to enable repeated access to facilitate dialysis. So access, if it is hemodialysis you're going to get, that means access to the circulation. And if it's peritoneal dialysis, you're going to have access to the peritoneal cavity or abdominal cavity. Now, dialysis is very important because it's necessary to sustain life. And it often starts at when the kidney function is less than 10%. And it's very important that we understand that the quality of dialysis impacts on the quality of life and also on the survival of the patient, how long the patient is going to live. That means if you don't get good quality dialysis, it's not good. Now, the quality of the access that you have will impact on the quality of dialysis. If you have a very good access, then you're going to have very good dialysis. And then if you have very good dialysis, you're going to have very good quality of life. And if you have good quality of life, you are likely to survive for longer. So access is key. It's very, very important. Therefore, what's an ideal access? What does it look like? An ideal access is safe, it's reliable, it's user-friendly, and it delivers prescribed dialysis dose. Now, the decision making actually is in steps. The first decision to make is, what type of dialysis am I going to get? Are you going to have hemodialysis or peritoneal dialysis? Then next, what type of access do I need to achieve the dialysis I'm going to get? Do I need an AV fistula? Do I need an AV graft? Do I need a tunneled neckline, or do I need a Tenchkoff catheter inserted into the abdomen for peritoneal dialysis? Then the next step is, where do we site the access? Is it going to be in the upper limb or lower limb? If it's in the upper limb, is it going to be at the wrist or is it going to be at the elbow? And if it's an elbow or wrist, is it going to be a graft? If it's in the lower limb, is it going to be a graft? Now, all this is very, very important. And then the next thing is timing. Timing is crucial because the access has to be placed at the appropriate time. And appropriate time for each person is different. Everybody is different. Your need is different. You don't compare yourself with somebody else. So it's got to be timed appropriately because the goal is the access has to be functional and ready to use before the need to start dialysis. That's why the timing is very, very important. Now, how do we get this right? Early discussion with the kidney specialist is very, very important. Education. The kidney specialist will want to go through a detailed history, age, how much urine you're passing, 24-hour urine output, home environment, who is at home with you? Do you have space in your house? What's your personal hygiene like? What's the social support you got around you? Are you an independent person? You can look after yourself very well. Are you self-employed or you are a student, in education? What are your personal preferences for hemodialysis, peritoneal dialysis that will suit your personality, that will suit your lifestyle? Then you have to make your decision before the need for dialysis. Unfortunately, it can be very difficult for some people to make decisions because it's very, very important you make your decision early because the outcome is better if you make your decision early and a permanent access has been created for you before you start dialysis. The outcome is much better. That is why we have to do this. Now, what are the type of dialysis you have to decide on? Hemodialysis or the blood type of dialysis, and it could be at home. They can install the machine in your house and you can do your dialysis with some help, from the nurses coming in to help you, or you may have to have hospital hemodialysis, what we call in-center hemodialysis. Or if it's peritoneal dialysis, there are different types of peritoneal dialysis. We have the chronic ambulatory peritoneal dialysis, what we call CAPD. And you have what we call the automated peritoneal dialysis, where you need a small machine that you can use at home. And we have what we call assisted peritoneal dialysis, when somebody comes in to help you. Or you also have assisted APD. Now, there are different types of access that is possible that we use for dialysis. So we have to choose what is appropriate for a particular person, depending on their situation, depending also on their choices that they have made. Now, this is how we do it. There are hemodialysis catheters that we use. We do not like to use catheters if at all possible. Catheters has their advantages and disadvantages, but if we can help it, we do not want to use catheters at all. If we have to use catheters, they could be placed either in the neck or in the groin. The necklines could be non-tunnel catheters, which you can see here, which is in the neck of this first photograph here. It's a non-tunnel catheter. It gets infection in it very fast. So that's why we don't like it. It's got to be removed within 5 to 7 days because it gets infected quite quickly. Now, the other one is a tunneled dialysis line or tunnel catheter, like this person here on the with the line in the chest hanging from the chest wall. This one has a lower risk of infection and it can stay in for months, sometimes years, compared to this one on the neck. So this is the one that we use for long-term dialysis for those patients who need such dialysis. Now, we also have femoral lines like this one here, which can be put in the groin. This can be put very quickly. We use it for patients who need to have dialysis very, very quickly, who become ill quickly. They come into hospital, they need dialysis now. It cannot wait. They have a femoral line because it's very quick. It can be done by any of the doctors. Then we also have arteriovenous fistula, of course, which is the gold standard for access for long-term hemodialysis. We call it AV fistula. This is what it could be put in the wrist or in the elbow, depending on certain conditions. And we have the arteriovenous grafts. That's a piece of plastic which can be put in the upper arm or in the thigh. If it's put in the thigh, it looks like this. You can't see anything. It's actually buried under the skin. They can just put the needles in and have dialysis through these two catheters here. These are thigh grafts that you can't really see, and it can be really hidden. And then you have the peritoneal dialysis, which is something we put in the abdomen. So we have to make decisions as to what you need, and this again has to be timed appropriately to get the best outcome. Now, how about native AV fistula? It is the best access for long-term hemodialysis. I keep repeating that. And when we do decide to put a fistula in, we have to make other decisions. That is, we have to decide on where we site the fistula. It's going to be in the non-dominant hand, and it's going to be sited first as distal as possible. And because vein, we want to consider using a vein before we consider using a graft, because vein is a natural material and it lasts longer and is better than grafts. Grafts can get infection on them easily and they have to come out. Now, if we're going to use a vein, we have to do a vein mapping, which means ultrasound scan of the veins of the upper limb. And then we're going to also have a surgeon have a quick look at the arm and have some to assess the quality of the artery and the vein. And then we'll decide on what is the best site that will give the best chance of success. Again, everybody is different. So the decision that will be made based on the person's circumstances. So this is very, very important we note that. Now, the patient's preference is also very important. So the surgeon will decide with the patient what is the best place to put their fistula. Now, the next step to decide on is to put the patient on the list for surgery and agree a date for the operation. Then the patient comes back for pre-op assessment, and then we do all fistulas by day case surgery under local anesthesia, except if the patient requests for a general anesthetic. And what we do in theater is very simple. We just join a vein and the artery together and under local anesthesia, and that's it. It takes about 1 hour operating and it's all done. And we have to wait for about 4 to 6 weeks for the fistula to develop and to show that it will be good enough, to be useful for dialysis. So we're going to do a post-op duplex scan, another ultrasound scan of the fistula to check for maturity. After that, we're going to look at the result, and then we're going to monitor the patient very closely at the nephrology clinics to make sure that the fistula is okay and there are no issues. And if there are issues, the patient is referred back to the surgeon and we deal with the issues appropriately. Now, the timing of creation of access, like I mentioned earlier, is very, very important. Now, to be able to make sure that we do the access early, sometimes we have to start discussing about the type of dialysis first, because if you don't, then you cannot decide on the type of access if you don't know the type of dialysis. So we start this discussion usually as early as when the kidney function is about 30%. For some patients find this a bit off-putting. They say, doctor, this is too early. My kidney function is fine. I'm feeling okay. What are you talking about dialysis? Please go away. In their heart, that's what they are thinking. But, this is because it's very, very important that we get the timing right, because you get the best outcome for the patient if we get it right. Now, early referral to the surgeon has been shown to be of benefit to the patient, especially when the eGFR is less than 12, so that the surgeon can put the fistula or the access in before the start of dialysis. It's very, very important. I will keep repeating this. Now, the surgeon will discuss the options, the pros and cons of the operation, and the possible complications of the operation, be able to answer all the questions that you may have. And like I said earlier, choose the appropriate site to locate the access to get the best outcome for the patient. There's a waiting list for surgery, for access surgery in the NHS. So it's good you get on the waiting list early so you can get an early operation. Very, very important. So what are the advantages of AV fistula? There is less risk of sepsis, which means that there is a reduction in how much time you spend in hospital. That's what most dialysis patients want. They want to stay away from hospital and have better quality time outside the hospital with family and friends. Fistulas are likely to deliver that. Now, also, they last longer than lines, and they enable better quality dialysis. With a fistula, you can have a shower, you can swim, you are free. You don't have a line, a tube dangling from your neck. And if you have an autologous fistula, which means that you don't have a foreign body under your skin, which is really good. So the risk of infection, that's why the risk of infection is low. And you can have your home hemodialysis option if you have a fistula than if you have a neckline. Now, what are the disadvantages? You can get bleeding from fistulas. Some people complain of pain, numbness, pins and needles, and digital ischemic steel syndrome because of reduction of blood flow to the fingers, which we see in about 2 to 10% of patients, especially patients who have diabetes, who are older patients, who are smokers, or fistulas were done at the elbow area. Now, there are other problems of AV fistula, aesthetics. Many patients, because if fistulas does form lumps and bumps and skin discoloration, it gets bigger over time. Some patients describe it and say, oh, it looks ugly. I can't wear what I want. I can't wear short sleeves. I can't even wear sleeveless, dresses. I don't like it. Some people, it creates some body image issues for some patients, but with time we can help. We have, help is on the way to try to help people to adjust and to be able to benefit from the best form of treatment, the best access for dialysis. Some patients also say it's noisy at night, that it may disturb sleep, but most people get used to it after a while. Now, how about peritoneal dialysis access? Is the best option for infants and children less than 2 years old, and also is good as an initial renal replacement therapy. And it gives an option to swap from hemodialysis if a patient is undergoing or experiencing problems on hemodialysis. Especially, it's good for patients who have residual renal function with no significant associated comorbidities like heart disease, lung disease, or liver disease. And also, many patients prefer to have hemodialysis. It gives you time away from the hospital. You can, do it at home, but it requires a lot of training. Unfortunately, not everybody can benefit from hemodialysis, especially if you've had extensive abdominal surgeries in the past, or if you have a stoma, if you have a big hernia, or you have a very high BMI or obesity, or you've got some problems with cognitive issues, or you have issues with personal hygiene for whatever reason, or you have problems or issues with housing, no space in your house to store the fluid. Now, the operation is very, simple. There are different techniques that we use for inserting the Tenchkoff catheter. We either do it percutaneous technique, which you can do outside the operating theater, or we do it laparoscopically under general anesthesia, or we do open surgery with a small cut, as you can see here, just a little cut there, and we can insert the tube into the peritoneal cavity. This is how the tube looks like. It's got a coil like a pigtail at the end of the tube. Again, the goal that we set for ourselves is we want the access to be functional before they are needed. Very, very important. To be able to achieve that, we have certain criteria just to help us, to guide us. Tunnel catheters, for example, has to be placed 72 hours before hemodialysis, the first hemodialysis. AV fistula needs to be placed about 6 months before hemodialysis, AV grafts 1 month, and peritoneal dialysis catheter at least about 6 weeks, at least before the start of peritoneal dialysis. These are some of the standards that helps us guide us as to what we need, how well we need to handle this issue of dialysis access. 60% of patients with end-stage renal failure should start their dialysis with a permanent access in every center in the UK. And 80% of patients who are on long-term hemodialysis should dialyze with a permanent access, like an AV, fistula, a graft, or PD catheter. And 80% of PD catheters should be patent at 1 year. That's if it's not, then the center is not doing well. So they need to find a way to do better. So in summary, timely placement of dialysis access ensures that the patient have the best, their first dialysis using the safe permanent access, leading to a better outcome compared to the use of temporary access types. Timely referral to the surgeon, not because I'm a surgeon, but it does help. It ensures that a working permanent access is in place before the start of dialysis. The decision has to be made in a timely manner about the choice of dialysis, the choice of access that fits the patient's lifestyle. Thank you very much. I'm ready for your questions.
Okay, so hi. Whilst you've been talking, there's a few questions that have come through. The first one, most of the questions are anonymous. So the first question says, how can the fistula site be kept clean, and what can be done to alleviate discomfort?
Okay. Yeah. Now, what we do, for the fistula site, usually, if the patient has just had the fistula, there is no marks on the skin. So the skin should just be cleaned as normal. You have a shower as normal, you clean it as normal. There's nothing special that you need to do. But once you start using the fistula, it becomes more important that the needle points or the breaks in the skin, as a consequence of the needle points, are kept clean all the time, usually protected by a small dressing, until the needle points are healed. So that's what you use normal, solution, antiseptic solution to wipe it. Usually the nurses will do all that for you at the dialysis, unit. They will clean it and they will put a dressing over it for you until you come back for the next dialysis. That's what we do mostly in most centers. Now, can I take the other question that was asked about living donor?
Oh, yes. Yeah, that was asked before we went on break, yeah.
Yeah. The question about, does a living donor have to be related to me? The answer to that is no. And the reason for that is, number one, this time we have what a group of living donors we call altruistic donors. So anybody on the transplant waiting list or disease donor waiting list can receive, if they are lucky, an altruistic living donor kidney. Okay. Unfortunately, it's a very small percentage of patients that are that lucky to get a living donor kidney. Okay, now so that's possible. Then we also have what we call the living donor sharing scheme. The UK transplant organization has a very brilliant program which they have arranged to enable people who cannot donate to their family to actually donate, so that we call it shared kidney scheme. So living donor kidney sharing scheme, we call it. So if a relative or anybody, a friend, can donate to you by law now, a distant relative can donate, or a complete stranger can donate to you. Anybody who donates even if they are not a good match, they can get into the sharing scheme. And if we can match them with somebody else, another recipient in another center in the UK, we can organize the transplant. So they swap kidneys. So the person donates to somebody else, then somebody else will donate their live donor kidney to you. So you can receive a living donor from somebody who is not related to you that way.
Okay. So there's another question, Philippa LCC. Thank you very much, doctor. Please, can an aged mother of 70 years old donate her kidney to her daughter?
Yes, it is possible to do that. So what we will make sure is that the mother is well. She doesn't have significant medical problems like heart disease, hypertension, diabetes, lung disease, and all those problems. And also the mother or the patient must have very good kidney function, so that when they do give one of their kidneys, they will still have good enough kidney function to manage their lives, to live normal life. So yes, we do take kidneys from 70-year-olds from live donors.
Okay. This time we've got a question from Ade Olaiton. Do you think the African and Caribbean think it is the NHS's responsibility to find their relatives and friends a kidney rather than putting themselves forward to be a living kidney donor?
I think like I said in my presentation, if you want a kidney quicker, the best way forward for anybody with kidney failure is to get a kidney transplant. And the quickest way to get a kidney transplant is from a live donor. And the most likely person that will give you a kidney is your relative. So if you want a kidney quickly and to get the best form of treatment for end-stage renal failure, then the relative should be donating to you. Somebody should come forward. So we have already said we've removed the blocks from relatives who are not good match, now can donate. Even though they are not good match to you, they can still donate a kidney indirectly to you. So it's still possible now. So all we need to find out is that we do the workup for the relatives and make sure they are fit and well. We are not going to harm them by taking a kidney from them, or they don't have any other medical problems that may make it not in their interest to take a kidney from them. If all that is fine, matching is not a problem. We will put them on the kidney sharing scheme, and we will try to find a match in the country. So they will donate to somebody else, and then that somebody else will donate to you. So now, ideally, that's the quickest and way to get a kidney transplant. If all that fails, then the deceased donor kidney transplant waiting list is the next option to get on the list, and then wait for your chance to get a kidney on the deceased donor waiting list.
Okay. So I think that brings us to a related question. I'm not too sure it was explicitly answered in the question you've just answered. It's asking, why is it that my siblings cannot donate their organ or kidney even though they share the same genes?
If your siblings, it depends on their circumstances. Okay, so for example, if you have a sibling that is 17 years old, it's unlikely we will want to take a kidney from a 17-year-old. If you have a siblings also that has some concomitant medical problems, they may not be able to donate to you because they may have, it may be to their disadvantage to donate to you. Also, sometimes there are certain kidney problems, diseases that run in families. So if we've done some genetic tests and we think that the disease, what caused your kidney failure, may also cause kidney failure in one of the members of your family, then we will discourage the person from donating to you and say, look, there is a good chance that you may also get the same problem. But it's all your choice if you still want to go ahead. Because what we think does not mean it's going to happen. It's just the chance that it may happen. So sometimes also if you are not a good match, then your relative may not be able to donate to you. So if you have different blood group, you might have the same genetic whatever, but if your blood group is different from that of your relative, then they may not be able to donate to you. So, but it doesn't mean that you will not get a live donor kidney. We just, put the relative on the sharing scheme, and you can still get a live donor kidney through the sharing scheme.
Okay. You mentioned earlier that a 17-year-old can't donate their kidney, or you wouldn't take kidney from a 17-year-old.
Yeah.
Can you explain why?
Yeah, by law, the 17-year-old is still too young, and you got to be 18 to be able to, by law, to be an adult and to be able to make independent decisions about your body, about yourself, your future, about everything. So if you are less than 18, we will say, please, you can wait, till you are legally able to make such decisions yourself.
Okay, so it's more a legal reason rather than
it's mostly legal. Mostly legal reasons.
Okay, thank you for that, doctor. I have another question here, if there's still time. This person is saying that they have received transplant abroad. Can they continue to receive their treatment with the NHS in the UK?
Of course, yes. If you've got a kidney from abroad, we do have a lot of patients in our centers around the UK who got their kidney from somewhere else. Once you are registered, you have the right to reside in the UK. Nobody will deny you treatment in any hospital, any transplant center. What you need to do is you just tell your transplant center where you received the transplant to get in touch with the center close to where you live. The transplant center, if you're in Manchester, is going to be MRI, or Salford. If you are in Preston, it's going to be in Preston. They write to them, giving the information about your operation, about what they did, about the matching, about, all the issues. So they will be able to look after you very well. So everybody will be looked after. It doesn't matter whether you received a transplant somewhere else.
Okay. So there's another question. If I have dialysis for 3 months before transplant, is it as good as Transplant First?
Anytime it is not as good as Transplant First. Transplant First is better than dialysis and transplant after dialysis. No matter how long the dialysis, how short you had the dialysis, it's always better to have your kidney transplant first before you have dialysis, because you are going to be in your best possible condition. So you are going to be, the operation is, going to be easier for you. Once you have dialysis, you have all sorts of other issues that needed to be sorted out. And, that may complicate your operation. It's just best to have your kidney transplant before you have dialysis. All the time is better. That should be the goal for everyone.
Okay.
So if you cannot get a kidney, then fine, you have to have dialysis and then you get your transplant. Of course, if you have your transplant 3 months after starting dialysis, is better than transplant 20 years after starting dialysis or 10 years after starting dialysis. If that's a question you want to ask, yes, that's true, it's better.
Okay. Okay. There's a very, very basic question here. Somebody is asking, how does dialysis replace the work of the kidney?
So, yeah, I think I tried to answer that question in my talk. Dialysis attempts to replace the work of the kidney to an extent to keep the person alive, to the extent when it does keep that person alive.
Okay.
So that's it. Dialysis cannot completely replace the work of the kidney. If not, if it can, then, we should all be having dialysis.
True. Okay. Thank you, Doctor. I would now hand over to Hilaria for the next.
This is amazing. Thank you very much. I am learning a lot. I thought I knew everything, but it looks as if I don't. So the next question that came through is, how can the fistula site be kept clean? And what can be done to alleviate discomfort?
Okay. Yeah. To alleviate discomfort, it depends on the type of discomfort that you're getting from a fistula. If you are getting a discomfort like pins and needles, and maybe the hand is feeling a bit cold or feeling numb, especially when you lie on it.
Yeah.
You lie on the arm, and then after a while you find, I can't feel my arm anymore, or can't feel the hand because it's gone numb. All you need to do is to get a ball and squeeze the ball many times in your hand, like hand exercises. And that will improve the circulation to the hand, and that helps to relieve the discomfort that you're getting. And then the next thing is, if that is not relieved, then you need to see the surgeon. Ask to be referred to see a access surgeon who will do some tests. He will examine you, do some tests to find out why you are getting discomfort. Because sometimes there are other reasons apart from the fistula that may be causing discomfort in your hand. There's something we call carpal tunnel syndrome, which the nerve in the wrist is trapped by some swelling at the level of the wrist that causes discomfort in the hand, which may not have much to do with the fistula itself. So these are some of the things that we need to figure out why you are getting the discomfort. That's what the surgeon will try to figure out. Sometimes it's due to neuropathy, due to some other problems in your neck. So all these things, the surgeon will figure out to find out why. Then he will be able to tell you, what he needs to do to relieve the discomfort. Okay.
Thank you for that. Why does the fistula site itch?
Yeah, like any place, for some patients, it's not just the fistula site that itch. Sometimes the rest of the body itch. When you're on dialysis, we don't fully understand. I'm not a kidney expert in this. I'm not the nephrologist will tell you that itching is a common problem with dialysis patients generally. And they have some treatments that works very well to remove the itching. But the fistula site if you have an area that is been needled, like any part of the skin that is healing, you find that it starts to itch when the healing process is a bit more advanced. And that's natural. It's just because you have needles, you have wounds at the site of the fistula. When you stick a needle each time, there's a small, tiny wound. When it heals, it's going to itch a bit. And then the itching will go very quickly. There's nothing to worry about.
Okay. I think this one is just about similar. I think you answered it, but I'll just ask it anyway because they'll be waiting to hear your opinion. Why do patients get cramps, and how can this be treated?
Cramps in the legs or cramps in the hand?
Well,
I'm not sure what they're asking for.
I think probably they're talking about cramps all over, because I, as a kidney disease patient and transplant patient, I do get those cramps as well. So it's all over the body. So it could be in the mouth, it could be in the cheek, the body, hands, muscles, everywhere, calf, toes, fingers. So it's really, really painful. So I think that's what the person is trying to say.
Yeah. These are not the issues that I normally deal with as a surgeon. Where if you have those problems, I usually ask my nephrology colleagues to see the patient. Okay. I think generally, it's because of some biochemical problems that needs addressing. Okay. That cause all those cramps. So they might have to review your dialysis. They look at your blood result and see which is high, what needs to come down, and all the other stuff that they do to try to make it better. So, but I do not deal with this problem on a day-to-day basis myself.
Okay. The next question, why does the fistula site buzz?
Why does it buzz? That's a nice question. Yeah, when you join a vein and an artery together in the arm, blood flows from the artery into the vein. Now, the vein is not designed to receive arterial blood. It's designed to receive venous blood, which is low pressure, low flow. But when you attach the arterial blood, which is very high flow, high pressure, to a low pressure system, what happens is that the blood rushes into the vein, and the vein, because of the rush in the blood into the vein, the wall of the vein vibrates, and that's what you hear. When you put your hand on the vein, it vibrates. The vibration of the wall of the vein is what you feel, which is completely different to when you are feeling the pulse on an artery. Yeah. So that's the reason, because the systems are designed differently to receive different. But when we do a fistula, we are creating an artificial joining of artery and vein, which they are not in nature. They are not joined together, but we are joining them together. So you go to get something different. And that's the vibration you get to show that, no, you should not be doing this.
Okay. Okay, so we have another question from YouTube. Is there a special diet for a kidney disease patient before and after transplant? Of
course, again, this is a nephrology question, but I will try my best to answer for a surgeon. The diet for kidney disease patient, yes, there's a special diet for kidney disease patient. And after transplant, if you have a good working transplant and there are no issues, you don't need to be on any restriction. So you can go to your normal, you eat normally. If you have a good working kidney, you don't need to have any diet. Just go back to normal. But while you're on dialysis, every dialysis patient will be prescribed a special diet. They will tell you, depending on your blood result, depending on what is going on, they will tell you exactly what you need to do. When you go to dialysis, any dialysis unit anywhere, you'll be clearly informed what to do in terms of your diet.
Okay. That's a lot more. Most of my relatives live abroad, and getting a visa will be a challenge. Can they still donate?
Yes, any of your relatives can donate, even though they are abroad. What you need to do is to find a center abroad who can do the tests such as their blood group, their HLA type, and do the basic tests to test that their kidneys are working fine. They don't have any comorbidities like diabetes, hypertension, or liver disease. They don't have any infections like HIV, hepatitis C, hepatitis B, and all those sort, HTLV, and all those sort. They don't have any things that may make it impossible for them to donate to you. And then they send the results. And then the center where you are having your dialysis or where you are being treated will look at those results, and then they will communicate with the other center abroad, and they will come to an agreement as to whether they feel like that whoever they are evaluating is able to donate a kidney for you. And then they will start the process of processing the visa to come into the country. There is no law that says they cannot donate. They can donate. They have to be able to show that they are your relatives. There must be proof that they are your relatives. That's one of the where a lot of people have problems.
Okay. This is another question. I'm a shift worker. Am I better off with hemodialysis or peritoneal dialysis?
It depends on other factors about you. Do you have space in your house to stuff peritoneal dialysis fluid? What is your motivation like and your drive like? Because peritoneal dialysis, the type of peritoneal dialysis that you will have, will depend on so many other things. Are you going to get an APD? Are you going to have CAPD? And so all those things has to be determined first if you want to have peritoneal dialysis. Peritoneal dialysis, that gives you that freedom to be able to work and do things that you want to do. If you have to have hemodialysis, you can still have hemodialysis at home. So whatever shift you are doing, you can plan your dialysis appropriately if you are on home hemodialysis. So you can do either one, but the decision about whether it's hemo or peritoneal dialysis has to be made based on other factors, not just because you are doing shift, because either can work for you if properly arranged. It can work. So, and it depends on you too. And so that's the way it works. So the choice has to be made based on so many factors, not just one factor, that is your work.
Okay. I think this one about I'm a student in university. How can I have my hemodialysis in term time and over the holidays?
Yes, you can. You can have your, if you are doing your hemodialysis in center hemodialysis, during your holidays, what you probably have to stay in the hostel. I'm sure many universities in the UK we do have the arrangement to allow you to stay in the hostel if you need to, while the other students have gone. So you can still have your hemodialysis. You go for your if you are doing in-center dialysis, which I think you will be doing if you are a student. So yes, that's possible. You can do that. The dialysis center will continue to attend to you, whether you're in school or you're on holiday.
Okay, that's great. So I'm going to pass over to Oscarine now so that I can take some more questions that have come over WhatsApp. Oscarine, you take it away.
Okay, I'm just gonna go to chat now, so maybe you're not gonna be able to see me to read the questions. I've been referred for dialysis access, should I be thinking of transplant first?
Okay, no. No. If you have been referred to have dialysis access, you should not be taking off transplant first. If they are planning for you to have dialysis, it does not mean that you will not have a kidney transplant when one becomes available for you. It just means they are planning for the two at the same time. So whichever one comes first, you go first. If on the day you are supposed to have your access, a kidney becomes available for you, of course, what will you choose? Will you rather go for access surgery or you go for transplant surgery? Of course, you will go for transplant surgery. So you just cancel your access surgery and then go for your transplant surgery. Even if you have your dialysis access and it's just freshly made, and the following day after your access, they call you to come in to receive a kidney transplant. Of course, you pack your bags, you go to the transplant unit and you get your kidney transplant. That means you don't need your dialysis access anymore. If you get a good kidney and the kidney works straight away, everything is fine. So you can keep your access if you want. If you don't want to keep it, you go back to the surgeon and tell them why you don't want to keep it. So it's not either. You can have both. It's okay.
Okay, thank you. Is ESFR of 15 same for Black and white patient in terms of transplant first?
For everybody, that it is the same. Whatever your race is the same to get onto the transplant waiting list. Your kidney function has to be about 15%. If it's higher than 15%, then you cannot be active on the transplant waiting list. It doesn't matter your race, it's the same. And the reason for that is to make sure that only people who actually need a transplant actually receive a transplant. And we don't want to transplant people too early. We've been talking about transplanting people too late, but at the same time, we don't want to transplant people too early.
Yeah.
So, okay.
Okay, carry on, please.
Yeah, so that's the reason why it doesn't matter whether you are Black or white or whatever, Asian, is the same criteria for getting onto the transplant waiting list.
Okay, next question. I am unable to sleep at night since I received my transplant. Why is that?
Okay. Immediately after, if you've been on dialysis for a very long time, a transplant may change your normal body clock, body rhythm, because it changes the way your body works and everything. For some people, it may, if for example you've not been able to pass any urine at all, you've been on dialysis for 10 years or 15 years or so, but you've not been passing any urine, and then you get a kidney transplant, you'll find out that you'll probably be waking up every hour to pass urine. So you're not going to be able to sleep at night initially, but that will get better. It's because the bladder is too small. It cannot store more than a few mils of urine at a time. So you have to go to the toilet to empty your bladder at a time. So the other reason for some people might just be because their body has changed and they are just trying to get used to. Their life has changed. They are just trying to get used to the new life. Just like some people, they go to a new environment and they can't sleep because they like to sleep on their bed or whatever. So, and there's no good reason for that. It's just over time, when you adjust, you will be able to sleep. You don't need sleeping pill. After a while, things will normalize and you'll be able to sleep well at night. So the kidney is not the cause of you not sleeping. It's just a change that the kidney has brought about in your body that your body is trying to adjust to.
Okay, thank you. 1 second.
So thank you, Dr. Campbell. That was really awesome. I think there's one last question, which I think Oscarine missed out. I travel up and down the country in my job. How can I access hospital dialysis if I'm away for a few days?
If you the type of dialysis that you will need if you have to travel because of your job, the type of dialysis that you can go about with, because if you travel to somewhere where they don't have hospital dialysis available in the area you are working, then it's going to be really difficult. If you work on a rig in the North Sea, where there's no dialysis there, and you have to be there for 2 weeks at a time. Of course, there's no dialysis on the rig. You won't get dialysis there. So there has to be another way to dialyze, and one other option is either peritoneal dialysis or some which you can do as you move around. That's why they call it chronic ambulatory peritoneal dialysis. It's a bit difficult to adjust to, but that's another possibility for you to be able to do that. But if where you travel, if you have if you know where you are going and you are traveling to a city where hemodialysis is available, and you plan it with your dialysis center, they can arrange with the center, the city where you are going, for slots, for dialysis slots for you wherever you are going. That's possible. So you can go to London and get dialyzed in London, and the next one you go to Edinburgh, you get dialyzed in Edinburgh. You go to Newcastle, you get dialyzed in Newcastle. That can be pre-arranged, but they need plenty of time, plenty of notice to be able to do that, because dialysis slots they are not easy to come by. They are quite tight at the moment. As we know, COVID has really caused a lot of challenges for dialysis patients. The slots are going very quickly because a lot of patients are on dialysis who should not be on dialysis. They should have had a transplant, but they can't have a transplant because there was a lockdown. So yes, it is possible, but it can be difficult.
Okay. I have a question.
Yeah.
You talked about the workup up to dialysis, preparing patient for transplant.
Yeah.
And I would like to know if there's any psychological workup to this pre or post transplant, because I'm asking this because I know that in France, they have a follow-up. They have a psychologist that follow them pre-transplant and post-transplant. Is there anything like that in England? I didn't have it when I had my first transplant and my second transplant, so I don't know.
Yeah, we do have a psychologist in every, I would think we have in MRI, we have in Salford, who will look after patients while they're on dialysis and also after they've had a transplant. But it is by referral. It's not automatic. So what I'm saying is, maybe there are about 600 patients on dialysis in MRI. The psychologist, we have only one psychologist. He cannot see 600 people. Okay. So what they have to do is you have to refer the nephrologist. If a patient has a psychological challenge, he needs to speak to the nephrologist looking after them. And that nephrologist will now refer the person to the psychologist who will arrange to see them. So yes, we do have psychologists who look after transplant patients and also dialysis patients in the UK. But it's not routine for it doesn't see every patient because not every patient needs psychology support.
Okay. Is there any more questions? Let me see.
Well, I would like to thank Dr. Campbell. We've all been talking to you. I'm sure you must be exhausted now. That was simply amazing. In fact, I don't know how to thank you. It's been a really informative session, and I hope everyone who's been on this webinar today has had the same experience that I have had, because you know, when you look at it, you think it's a small subject. It's not really a big issue, but it is, because there's so many intricacies, some weaves and turns that, you know, you never know. And all this information it's really, really good. Just also for people who are going to be going into dialysis or becoming transplant patients. I think it's really amazing. Thank you so much, Dr. Campbell. We really, really appreciate you being here today, taking the time of your Sunday to come and spend 1.5 hours talking to people about Transplant First and dialysis access options. We would love to thank you on behalf of everybody watching, both kidney disease and transplant patients, and also people who are listening from around the world, because I know that there are loads of people who have signed on both on Facebook and on YouTube as well, watching this webinar. And you've been awesome, Dr. Campbell, taking the time to speak to us today. Yemi, do you have anything to say?
I think you've said it brilliantly. I just want to second what Hilaria had just said. It's really amazing to have somebody like you coming out to talk about this really, really important subject. And if anything happens to me and my family, it'd be good to have somebody like you in my corner, is all I could say from what I've heard. It's quite impressive, and a depth of knowledge that's been shared. Yes. So thank you so much for your time. And I also spoke to somebody who knew you from King's Church, Ross and Irene. They send their hello. So thank you very much.
Oscarine, do you have any last words for Dr. Campbell?
Thank you so much, Dr. Campbell, for coming on and giving us this talk. I know that many people don't really know about renal failure, especially when it happens to them. They need to be educated, and you stress that education is really important, because when it happened to me, I didn't know anything about it, and my family either. So it's important that we get educated and know what's happening to us, and know the choices that we are out there that we can make for ourselves. So thank you very much for your time, and thank you.
Thank you very much, Dr. Campbell, and we hope you have a nice rest of the weekend. We know we're taking your time, and we're going to let you go so that you can go relax and for the rest of the weekend. I hope we can get you back next time to come and talk about living donation, because that is also an important subject that most people would like to learn about, and it's also a passion of mine to talk about, you know, living donation. So hopefully, once we have all that sorted out, we'll reach out to you again. And in case also, if we have questions from people, because I know a lot of people have not been able to put questions up, come on to put, oh, my goodness, okay. Somebody just come on, sorry, Dr. Campbell. Someone just come on with a question. I was just looking to see if I could put a lot of people's comments up of thanks. And I've just seen this. I'm sorry about this.
Yeah.
I don't know if the question, it says the employer should make reasonable adjustments for employees who need dialysis, ensure they aren't posted to locations where dialysis isn't available. I think that's probably in answer to one of the questions that Oscarine asked you. So it's basically not a question. So I'm going to put on a few people saying thank you. So that is Philippa LCC. And I think there's one from Ade Olaiton. And also, oh, this is from Jenny, and that is also from Jenny as well. So everybody's saying thank you to you. We really do appreciate it. Thank you very much, Dr. Campbell. So we'll let you go now. Thank you very much. And
Thank you,
have
Doctor.
a nice rest of the day.
Thank you so
Thank
much.
you. Thank you so much. It's been an honor to be here with you. Thank you.
Thank you. Okay, guys. So that was amazing, wasn't it? So
Are we still live?
it is been a really great day. I'm so excited about the information we've received today. I cannot express, the joy that we're able to get Dr. Campbell on screen on this webinar talking to all of you. I'm sure that most of us who've been his patients would appreciate him coming on today. Yemi, what did you think about the whole thing? The whole,
I think number one is just really, really good to put together something like this. Two, it's great to have, like you said, the caliber of Dr. Campbell coming to talk about the topics that he's talked about, and the wealth of information that has been shared, not just for the patients, but for the patients' family as well. I thought that has been it's been really useful, very good. I think it will enrich the family, it will enrich the patients. At least the family know what to expect, the family know what options are there, the family know when to step in and help patients make decisions when they're not really fully able to, for whatever reason, psychological maybe, shock, coming to terms with things possibly, but also for the patient themselves to know what they need to do, what options are out there for them. So this has been really, really good. And great job, Hilaria, for putting this together. And also Oscarine, fantastic job. Thank you for being here. And thank you for making me a part of this.
Yemi, a question just came up for you. There you go.
Awesome.
Do you want to answer that now, please?
Do I want to donate a kidney? If I want to, that's a very personal question. It's not a question I will be answering on Facebook Live. Thank you, Adi.
And Adi says thanks a million. So before we go, because we finish in 3 minutes.
Pardon?
We finish in 3 minutes. Do you have a few last words to say to everybody who's attended today?
It was really, really informative. I thought that he explained everything from what is the transplant down to what is dialysis, why you need dialysis. So it was really informative for anybody that didn't know about renal failure or kidney disease. For me, as you said, there's certain things that like I think I'm a vet, I'm a veteran. So I think that I know everything, but today I was just like, no, you don't. You don't. They're always
experts talking.
Yeah, they're always things.
Yeah.
There are always things that we don't know. So we're open to learning. We never stop learning. It doesn't matter if even he will tell you that it doesn't stop learning because he's a consultant. It doesn't stop learning.
Yeah.
So medicine is evolving. So we keep learning. So that's why we have to keep learning, even as patients, as family members, we have to keep learning.
True.
Yeah.
So, so we've come almost to the end of this, and I want to thank everybody for logging on and watching this webinar. Next week, we hope to bring an expert on blood donation, because as you all know, we are in need of blood in the UK, especially from the African Caribbean community in the UK. We are in need of blood, and we want people to come forward to to become blood donors. I was just talking to a few people in a group I belong to, and they were talking about issues with, traveling out of the country and not being allowed to donate blood. So those questions will be answered next week. So you don't want to miss that session next weekend. We'll put out the date, we'll put out the time as well, and we'll also let you know who the expert is. So watch out for our posts. We do post them on Facebook, on Twitter, on WhatsApp, all the platforms. So look out for those under the WSH BME network platforms. So that's Warrior Survivors and Heroes BME network. Thank you again for coming on. And I hope to see all of you next week. And thanks very much for honoring my invite. So I'll speak to you soon. See you next week. Bye.